June 1st today. I'm going to go ahead and begin with our land acknowledgement, and then I'll introduce our speakers. To remind us that Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. So I'm delighted to have a trio of presenters this morning. I think it's always interesting when we hear different perspectives around a topic. It really reminds us of the multidisciplinary care that we provide here. I'm going to present them. I thought this was the order that they were presenting, maybe a little bit different, but I'm going to start with Dr. Sarah Sawyer. Sarah completed her PhD in genomics at the Karolinska Institute in Stockholm, Sweden. She returned to Canada to attend medical school at the University of Calgary, and then completed her residency training in medical genetics, also in Calgary. Following this, she moved to Ottawa for a one-year clinical and research fellowship in neurogenetics and translational genomics. Sarah Sawyer is now a clinical geneticist at CHEO with focus in pediatric cancer syndromes. She also continues to be active in bringing next-generation sequencing technologies into clinical practice. Our next two presenters are from the Department of Pediatrics. Katie Muir in the Division of Neurology completed her medical degree at University of Toronto in 2011 and postgraduate training in pediatric neurology at University of British Columbia, finishing in 2017. She then went on to do a fellowship training in pediatric epilepsy at Columbia University, finishing in 2018. Her clinical and research interests include pediatric epilepsy, electroencephalography, and genetic causes of epilepsy or neurocutaneous syndromes. And then our third speaker is Dr. Muir-Sawyer-Thacker in the Division of Hematology Oncology. Muir has worked in pediatric oncology across 3 different continents. He did his master's in pediatric oncology at Tata Memorial Hospital, one of the largest oncology centers in Asia with nearly 2,000 pediatric oncology cases annually. He subsequently worked as a clinical drug development fellow at the Royal Marsden Hospital, which is a leading institution in early phase cancer trials in the UK. From there, he went on to SickKids as a hematology oncology fellow, doing a fellowship in pediatric neuro-oncology. His clinical and research interests include neuro-oncology, early phase clinical trials with novel cellular therapies, and their translation in neuro-oncology. This trio of experts is going to present to us on tuberous sclerosis with their intriguing title, Tuberous Sclerosis, Unravelling the Complex. And I believe Sarah is going to be joining us. So over to you, Sarah.
Thanks very much for the introduction. And Nirav gets full credits for our exciting and enticing title. Let's see. All right, so there's the 3 parts today. So I'll talk about the diagnosis of TSC, both molecular and clinical. And Katie will talk about the neurologic and neuropsychiatric aspect of TSC. And then Nirav will talk about the emerging treatment, targeted therapies and mTOR drugs and pathway. And this also sort of announces the soft launch of a TSC clinic that we're hoping to establish at CHEO that will be multidisciplinary with many more people, not just the 3 of us. That really shows the complex and multi-system nature of TSC and the really exciting treatment opportunities now that we have with precision medicine. So to start with the diagnosis piece here, so as I mentioned, there's both clinical and genetic diagnoses for TSC. And I'll talk about those as well as what we're doing in the research realm for the undiagnosed patients with TSC. So the clinical criteria have been established for a long time, and this works for most patients to provide them with a diagnosis of TSC. And so if you get 2 major criteria or 1 major and 2 minor, you have a diagnosis of TSC. Genetic testing can be complementary to that to help confirm the diagnosis. It can also be helpful in patients who are too young to fulfill clinical criteria or who have unusual presentations. We do genetic testing. So for the clinical criteria, we'll start with the major criteria. And these are features that are most specific to tuberous sclerosis. And so the first things that are often identified are the hypomelanotic macules on the skin. Infants are often born with these, or they present very early on in lifetime. The angiofibromas occur a little bit later in childhood and certainly more in adolescence and adulthood. And the picture of the nose there shows some angiofibromas. And I often tell patients that these look like pimples, but that they don't go away. And so the only way to really know if they're angiofibromas is to remove them and have pathology look at them. But this is what their typical appearance is. And then of course, there's the shagreen patch that we all know, the orange peel skin that can also be found on the back. Then on clinical exam as well, the angiofibromas, fibromas around the nails, lumps and bumps around the nails is also one of the major criteria. And the cardiac rhabdomyoma, this is often identified prenatally. So prenatal ultrasound echocardiograms often find cardiac rhabdomyomas in patients then who will go on then to have more features of TSC. Ophthalmological findings, retinal hamartomas can be seen in our major criteria, pretty specific for TSC. Then these last two on this side of the slide, the renal angiomyolipomas and the lymph angiomyomatosis, which I'll call LAM or LAM from now on. Those are not completely specific to TSC, and so their exception to the two major criteria is these two. These can be often seen sporadically in middle-aged adults and especially women. So that would count as one single criteria together. And then the brain findings, which Katie will discuss in much more detail there, the subependymal nodules, cortical tubers, and of course the sagas as well. They're all relatively specific for TSC. So any two on this page, with the exception of the renal AMLs and LAM, would give you a clinical diagnosis. Now, the minor criteria are less specific, but helpful in diagnosis. You have two minor criteria, one major, that will fulfill diagnostic criteria. And so on physical exam, look at the skin, finding those confetti lesions, those small white dots, as you can see in the picture there, would be a criteria. In the mouth, and you can see the picture there, those two black dots on the central incisors are the dental pits. And then the big mass there is an intraoral fibroma. On X-ray, the sclerotic bone lesions are back on the list of clinical criteria. And then imaging, kidney imaging can show renal cysts. So it's not just AML, but other renal cysts can make you also think about TSC. Non-renal hamartomas, as we see these in the breast, and then retinal achromatic patch as well. So if you've met clinical criteria, there's many other things that you should look for in a patient with TSC. Now, these are the common clinical features. These aren't part of the criteria, but these are often what are associated with patients who have TSC. So I think about them in two big groups, the brain and the kidneys. The brain findings together are referred to as TSC-associated neuropsychiatric disorder, or TAND. So seizures are very common in patients with TSC, ID as well, and up to 50% of patients. And then the other features there that go along with abnormal, atypical neurodevelopment, autism, ADHD, and learning disabilities. And then there's more to that as well, some mood disorders, psychiatric disease that Katie will discuss later on. And then the renal findings, so benign AMLs are common in patients with TSC. Most patients by early adolescence will have them. Renal cysts. Renal cell carcinoma accounts, or the lifetime risk is about 2%. That's not much higher than the general population risk in Canada. It's almost 2% for men and about 1% for women. So it's not that different. All right, now that we know the multi-system involvement, the surveillance is relatively straightforward and intuitive. So renal screening yearly for blood pressure, renal function, and then imaging every 1 to 3 years, depending on if anything's identified. And it's what's recommended. CNS screening, again, MRIs every 1 to 3 years. Of course, if lesions are identified, then a more regular screening is likely indicated. I want to highlight here the comprehensive evaluation for TAND. And so that currently is hard to access, and the recommendations are once every 3 years when looking for developmental delays and neuropsych and psychoed evaluations. And so we're hopeful that with the establishment of a clinic, we can provide better access to patients for that service. In ophthalmology, is recommended yearly. Cardiology is often once in a lifetime unless a cardiac rhabdomyoma is identified. So we don't expect these to develop later on. It really is a very, very early prenatal onset that often spontaneously regresses. And so if you identify a child with TSC at 2 to 6 years of age, which is sort of the average age, it's very unlikely that there'll be any cardiac lesion left. The pulmonary here, I said this is childhood surveillance, and the pulmonary is the exception. This is really adulthood. The recommendations are for baseline CT in females when they're early young adults, or if they're symptomatic. But this isn't something that we worry about in childhood. And then skin and dental exams on a yearly basis as well. So that works really well for patients who we've been able to diagnose with either clinical criteria or genetic criteria. We know what to do. But then there remains the patients who are undiagnosed. Genetic testing. Here we go. We'll do this one first. So genetic testing. So clinical diagnosis is great, and then this can be complementary. So there's two genes that we look for, TSC1 and TSC2. And this graph here on the left, you see that 1/3 of patients will have a mutation in TSC1 and about 2/3 in TSC2. And then unknown can be up to 15%. I know this says 5% here, but it's probably larger for reasons that I'll go into later on. And so when we do clinical sequencing, we read through the gene, that's the sequence analysis part, and most patients will have a typo or a spelling mistake in the gene. A very few patients, less than 1%, will have a deletion or duplication. When we order clinical testing, we do get MLPA for deletions and duplications, as well as sequence analysis. So all of this is covered with clinical testing. What you see here is that there are some patients that have a family history, so that 10% plus 14% will have a clinical history for either TSC1 or TSC2. And then the rest are de novo or simplex cases, so new in the family, new mutation. So you have a child with no family history of TSC, then the risk is, or the likelihood of a TSC2 mutation is about 50%. And the higher high rates of inherited TSC1 is likely due to the fact that it's probably less severe. There's less ID and seizures, generally speaking, in patients with TSC1 mutations versus TSC2 mutations. So then that leaves us with the unknown. And the unknown here, we're targeting with research studies through Care for Rare to look for these undiagnosed patients to provide them with a molecular diagnosis. And as you'll see through the talk, this is becoming increasingly important to find the genetic change because there are targeted therapies now available for patients with TSC. So what we're doing, or one of the things we're doing, is using sequencing through the Care for Rare project, which Kim Boycott leads, to look for mosaic patients with TSC. So what we see in the middle of this slide here is the cell. So mosaicism means that the mutation wasn't present in the egg or the sperm, that it arose after conception. So it could be the 5-cell embryo stage, 10-cell embryo stage. But what this means is that when you take the blood for testing, there's no mutation in the blood. And so the mutation arose in tissues that were not precursors to the hematopoietic cell lineage. So the blue cells in this picture are the ones with the mutation in it, and the gray cells are the ones without. So if you do normal sequencing, it gives you about 80-fold coverage. If you see one pathogenic variant, then the variant callers won't detect it. It'll be most likely due to an error. So you'll get a normal sequencing result. So to look for mosaicism, we need to have really deep sequencing coverage, up to 1,000-fold or greater. So you can see in the blue bars there, if you see the multiple reads that call the same pathogenic variant, then there's more confidence in the call. And it can be called as a mosaic result at 0.5%, 1%, 2%, 4%, whatever it is. And so this is one way that we're using to target mosaic patients who seem to have TSC, but we can't find the testing or the mutation in the blood. Now, the other way is to look for tumor tissue as well. And so tumorigenesis here, I'll just run through briefly. This is Knudsen's two-hit hypothesis. But on the left there, you have the two normal genes. So that's the egg and the sperm. There's no mutation present at conception. And then every time cells divide, they have to copy their DNA, and that's never perfect. It's always error prone. So if by chance one copy gets mutation in the TSC, which is the yellow box there, then that cell still has one functioning tumor suppressor, so it's okay. But then a second sporadic mutational event can occur. And then in that case, there's no functioning tumor suppressor with the TSC gene, and then that's how the tumors will arise. So this could be a cortical tuber, an angiofibroma, a SEGA. And so if you sequence that tissue there, then you'll be able to identify, hopefully, the first damaged gene. And if you do two angiofibromas, you'll be able to find the original hit. And then there's always going to be usually a second different hit in the tumor. This is another way to find mosaicism if it's not identifiable in the blood. And I'll just contrast that with an inherited tumorigenesis, where if all the cells in the body already have a single hit, because it was present in the egg or the sperm, then you just need one additional mutation event to cause a tumor. So this highlights that many of the features of tuberous sclerosis can be seen sporadically as well if you randomly have 2 mutations in the gene in a susceptible tissue. But if you're born with one copy not working, then you're likely to have a more severe phenotype, more features of TSC, because all you need is one additional hit to get tumors. So as I briefly suggested there, the phenotype in patients who are mosaic is often milder than patients who have classic TSC. So this graph here shows mosaic patients in blue, with classic patients with TSC with the mutation identified in blood in orange. And then the gray bar is patients who have no mutation identified even after deep sequencing or tumor sequencing. And so what we can see here, if you look at the blue bars compared to the orange, is that they're often lower. And so that means that there's less phenotype. So there's less hypomelanotic lesions when you look at the left. They have fewer cortical tubers. So only about 55% of patients with mosaic disease in the study had cortical tubers, compared to over 90% of classic or TSC patients. And then again, of course, seizures are much less, ID is less. So these phenotype being lower in mosaic patients suggests that it's not in all cells, and therefore patients are less affected. The no mutation identified ones are very interesting because they have almost very similar disease presentation to those with the mutation identified. And so that suggests that it's not deep sequencing or mosaicism that's the problem, that it's that our conventional methods of sequencing are not detecting all genetic changes. And so although I won't discuss it in any detail in this talk, we do have other methods like RNA sequencing and genome-wide sequencing to try to find mutations in those patients. So we've recruited about, I don't know, maybe 20 patients so far to the deep sequencing project here. And we've got some early results for this one patient here. And so you can see that he meets clinical criteria. He's got 4 major criteria there with the skin hypopigmentation, rhabdomyoma, SEGA, and AML. And he also has seizures. Conventional testing on blood was negative for TSC1 and 2. And that MLPA there means that we also looked for deletions and duplications. So he was a great patient to enroll for our deep sequencing project, and we were able to identify his change. So what you see here is those gray horizontal lines are the sequencing reads. And if I zoomed in really closely, you would see the actual base pairs A, T, C, and G on those lines. And because the sequencing is deep, we have lots and lots of reads, and I've just shown some of the reads here. The green bars in the middle is the actual base pair where the variant allele or the pathogenic change was identified. And as you can see, 2 there. And so it's just a fraction, that is how we get the 4%. So the fraction of the variant allele to the common allele is how we call the level of mosaicism. So in the TSC2 gene in this patient, there was a variant allele at a 4% frequency that was a splice acceptor variant that was deemed likely pathogenic. And so we were able to provide this patient with a molecular diagnosis that then complemented, obviously, his clinical diagnosis that he had. And this is important for things like recurrence risk as well. So it's 50%. And now we would have prenatal testing or targeted testing for other family members as well. And I'll just finish up with this slide here that shows a bit of a broader picture of the research project that we're undertaking. And so the arm 1 here is patients with things like TSC and other conditions where we know that they meet clinical criteria. And so we'll use a small, very deep panel to look for changes that are mosaic, that weren't available or weren't seen in conventional testing. The second group is patients who have a very recognizable clinical phenotype, but that there might be additional genes that could cause the same thing. And so for this, we're using a deep clinome, so it's deep sequencing on all known clinically relevant genes. So still thousands of genes, but looking at deeper sequencing at many, many genes. And the third arm is for patients who meet clinical criteria for mosaicism. That's based on this paper here that we've referenced there. Some TSC2 patients or TSC patients will fit that criteria. Occasionally we see angiofibromas only one part of the body. You can think about segmental NF1 patients as well who would meet mosaicism criteria. And so for that, of course, we're looking at getting good samples like the tumor samples and deep sequencing in the blood to look for mosaicism, as I mentioned. So this is a little shout out for enrollment. If you have patients you think meet these criteria, then we're happy to talk and try to get their diagnoses for them. And with that, I'll hand it over to Katie.
Thanks, Sarah. I'll just share my slides. Okay, great. So we've heard about how we diagnose tuberous sclerosis, as well as a lot of the really interesting genetic research that is being done in this group where we don't find a quick, clear genetic diagnosis. I'm going to switch gears now and talk about the main neurologic as well as the neuropsychiatric symptoms that we see in tuberous sclerosis and some of the therapies that we're using for these now. So starting with seizures, because seizures are the most common neurologic symptom that we see. Seizures happen because of the tubers in tuberous sclerosis. So Sarah showed you the major criteria that we see in the brain for patients with tuberous sclerosis. And one of those major criteria is the tubers. And so the tubers are pictured here on this axial flare MRI scan. You can see it's quite an abnormal area look in the brain. And so you've got this hyperintensity involving the cortex underlying white matter, as well as some associated hypointensity on the image. And what these actual areas of brain look like, these tubers, is that they are very disorganized. So within the brain, all of the cells should be organized into these kind of nice normal layers. Within the tubers, this organization is lost. And then within the tubers, it's not just the loss of organization, it's also that the actual cells, and especially the neurons, are abnormal. And so these H&E stains at the bottom show what a normal neuron would look like, and then what the brain within the tuber would look like, where you don't see any normal neurons. The neurons that you see here, the nuclei don't quite look right and the shape isn't right. And then they also have these very specific abnormal cells within them called balloon cells. And so within the tubers, there's this combination of disorganization, abnormal neurons, and these abnormal balloon cells. And all of these things together make these areas of the brain very epileptogenic. And so you get focal seizures that arise from these tubers. Patients with tuberous sclerosis don't usually have one tuber. They usually have many tubers if they're going to have them. And so they have many areas within the brain that are capable of generating seizures, although there does tend to be one or maybe a couple dominant tubers that generate most of the seizures for these patients. And so, of course, if patients with tuberous sclerosis have seizures, then they're going to have epilepsy. Epilepsy is very frequent in tuberous sclerosis, occurring in 80, maybe up to 90% of patients with tuberous sclerosis. And this epilepsy, it starts early. So 2/3 of them, the seizures will start within the first year of life. And a group of those, more than 1/3 of them, will have infantile spasms. And so infantile spasms is a very specific seizure type we see in infants. And it's a component of this West syndrome where you get infantile spasms, a specific pattern on the EEG, hypsarrhythmia, and it's associated with developmental stagnation and often developmental regression. So this is the most concerning seizure type that we see in infants with tuberous sclerosis because it really affects their development, especially if you can't control these seizures quickly, and these seizures can be very difficult to control. And so then if you look at all of the patients with tuberous sclerosis, about 2/3 of them will go on to have refractory epilepsy. And so this means essentially that medications are not controlling their seizures. We call epilepsy refractory if you've failed 2 anti-seizure medications. And so then if you look at all of the patients with epilepsy in tuberous sclerosis and which ones become refractory, the risk factors are really the seizures that start early and the seizures that are more severe, of course, lead to refractory epilepsy. So risk factors that have been identified are seizure onset, less than a year of age, infantile spasms, and then infantile spasms that don't respond to therapy. So epilepsy is one of the main neurologic symptoms. It's the main one that I see and treat. The other major neuropsychiatric symptom is this tuberous sclerosis associated neuropsychiatric disorder called TAND. This is essentially a cognitive profile that children and adults with tuberous sclerosis would have. And I would say every patient with tuberous sclerosis will have this TAND cognitive profile, but the severity can vary. And so some of them are very mild, but this can be very severe. And TAND is divided into these different realms where you can see specific dysfunction within the realms. So there's the behavioral level, and this is probably the biggest issue for the younger ones, the toddlers. We see a lot of really difficult behaviors, but they can persist right through childhood. And so things like aggression, temper tantrums, self-injury, impulsivity, and then they can have some sleep problems as well. They can have specific psychiatric diagnoses within this TAND cognitive profile. And so they can be diagnosed with autism spectrum disorder, ADHD, anxiety disorder, or depressive disorder. Sometimes they don't quite meet clinical criteria for a full disorder within this, but they have features of some of these as well. And then patients with tuberous sclerosis can have sort of a full intellectual disability of varying severity. Sometimes they have a more uneven intellectual profile, and this can present more as like a specific learning disability. And this comes into the academics as well. Sometimes they can have specific learning disabilities in one area, like reading or writing. And then the neuropsychological, so this is the kind of thing that you'd see on neuropsychological testing, where they may have difficulties with sustained attention, dual tasking, attention switching, memory, spatial working memory, and cognitive flexibility. And having any deficits in these areas obviously contributes to the academic difficulties that the children will have. And then finally, looking at the psychosocial. So this psychosocial realm encompasses psychosocial difficulties that the child has, but also captures the psychosocial difficulties within the family. So we see issues with self-esteem in these kids, self-efficacy, and then when you look at the family unit, there's major difficulties with parental stress and relationships within the families. And so when you talk to families whose children have tuberous sclerosis, the TAND, these neuropsychiatric symptoms, I would say often even more than refractory seizures is what is affecting quality of life for the child and for the family unit as well. So then taking a step back to why does this happen? Sarah talked about the genetics for tuberous sclerosis, that we have loss of function mutations in TSC1 or TSC2. These mutations are part of the mTOR pathway, which is pictured here on the side. And you can see the TSC1 and TSC2, they form a complex which is inhibitory within this pathway. If you mutate one of them, you lose the function of this inhibitory complex, and you end up with increased activation happening through the pathway. So this hyperactivation within the mTOR pathway. And so it makes sense that you get hyperactivation. It can cause proliferation of the cells, and this is why you get the tumors. This is why you get the cortical tubers. The hyperactivation in the pathway, though, is also thought in general to contribute to abnormal brain development. So not just within the tubers, but within the brain as a whole. And so this is sort of some of the effects that we think that mTOR has on the developing brain. So mTOR hyperactivation can cause disruption of dendritic spines, abnormal neurotransmission, abnormal synapses, and abnormal connections. So it's really affecting the way that the neurons are communicating with each other. And we think this happens throughout the whole brain. It contributes to that epileptogenicity within the brain causing seizures, but it also is what is causing the neuropsychiatric symptoms, or this TAND. And then we know that having seizures, especially in the group that has the refractory seizures, will worsen the neuropsychiatric symptoms. And that idea that epilepsy or seizures is worsening the neuropsychiatric symptoms is shown here. This is a study that looked at a huge group of patients with tuberous sclerosis and was able to looked at risk factors for having cognitive impairment, and showed that history of seizures, infantile spasms, early age at onset of seizures, refractory epilepsy, and epilepsy that was not in remission were all risk factors for having cognitive impairment. So we've seen that the mTOR hyperactivation on its own is likely contributing to intellectual disability, autism, the whole TAND phenotype, but also that early onset of seizures increases the risk of having a poor neurodevelopmental outcome and cognitive impairment. So there isn't anything that can be done at this point for that early mTOR hyperactivation and that abnormal brain development, abnormal connectivity that's happening mostly prenatally. But seizures start postnatally. And so this is something that we can try to target. So right now, the goal of epilepsy therapy in tuberous sclerosis Oh, I think someone's not muted. The goal of epilepsy therapy in tuberous sclerosis is to try to control seizures as quickly as possible to improve neurodevelopmental outcomes. And so this takes us to the idea of precision medicine, because in tuberous sclerosis, there are a handful of therapies now that are quite targeted towards this condition. So I'm going to talk about the use of Vigabatrin in tuberous sclerosis. I'm going to talk about epilepsy surgery, and then Nirav is going to talk to us about the molecular targeted therapies for mTOR. So starting with Vigabatrin, Vigabatrin is an old anti-seizure drug. It irreversibly inhibits GABA transaminase, prevents breakdown of GABA in the central nervous system. GABA is inhibitory, so if you have more GABA, you have more inhibition, you have less seizures. Vigabatrin works very, very well for tuberous sclerosis. Vigabatrin, its main use in all of seizures is to treat infantile spasms. But when you look at groups of patients or infants that have infantile spasms, it works even better if you have tuberous sclerosis as the cause for your infantile spasms. And so it's first line for patients with tuberous sclerosis and infantile spasms. It also is effective for treating other seizures in tuberous sclerosis, much more effective than you'd expect kind of in the general epilepsy population. And so Vigabatrin can now also be used to treat focal seizures in the first year of life. It's important to remember Vigabatrin comes with some significant side effects, retinal toxicity, and it can cause irreversible vision loss. And so the patients with tuberous sclerosis now, they're often on Vigabatrin for many years, whereas in other epilepsy patients, we would more try to limit the use to sort of 6 months to a year. And so these patients need close follow-up with ophthalmology to monitor their vision. So it makes sense that if you can catch seizures early, treat them early, hopefully you could improve developmental outcomes. But then the question was asked, what if you actually could prevent the seizures? And so that's what this study tried to look at. This is a study called EpiStop that was just recently published. And they took infants with tuberous sclerosis and they gave them Vigabatrin as soon as they saw any sort of epileptiform change on the EEG, so before seizures. And then they had a group where they just had kind of standard therapy where at the first seizure, Vigabatrin was started. This was a difficult study to recruit into, which is why you see in this results graph here, they have a randomized group, which is where they were actually able to randomize to early Vigabatrin versus routine care. And then they have an observational group where they had to just use what was standard of practice at the institution. And this is more in the States, but in the States, there are a lot of institutions now that actually give preventative therapy. And so they're comparing that to kind of the more standard therapy where you start with the onset of seizures. They were able to show that the preventative therapy, so starting Vigabatrin before the onset of seizures, reduced the risk of seizures, the risk of drug-resistant epilepsy, and the risk of infantile spasms. So these Kaplan-Meier survival analyses graphs here show in the red the conservative group, so standard therapy, and as they drop, they're sort of the lines drop as they're having seizures. And you can see within the 2 years that they followed these patients, only 15% of them were seizure-free by the end of that, which fits kind of our epidemiologic data suggesting that about 85% of patients with tuberous sclerosis will develop seizures in epilepsy. That's compared to the preventative group where the numbers developing epilepsy were more around 50%. So quite a significant difference in these groups. The caveats, of course, with this study are that it was small. They only managed to randomize 26 patients, and then they had 27 in their open label group. They were only able to follow them until 2 years, and so that really limited the developmental outcomes that they were able to look at. And so they weren't able to show a difference between developmental outcomes in these groups, probably a combination of the low numbers and short follow-up. But overall, this was an impressive study with the change that they were able to show in the development of seizures. And this is a study that is really changing practice for patients with tuberous sclerosis. And so based on this, in most tuberous sclerosis centers now, in most clinics, the infants will undergo screening EEGs to try to catch this epileptiform activity early before seizures actually start. And then I'm just going to touch briefly on epilepsy surgery because epilepsy surgery was not traditionally something that was offered to patients with tuberous sclerosis. It's just recently that this has begun to become really a standard of care and something that we think about early for these patients now. And the reason it's not sort of traditionally thought of for patients with tuberous sclerosis is because of what we were saying initially, that these patients have many tubers. They have tubers on both sides of their brain. All of these tubers are made up of abnormal brain tissue, and all of them are epileptogenic. So it was thought that if you take out one tuber, you're still left with all of these others. How could that really affect the epilepsy? But it turns out that, like I was saying before, it's usually one or a group of tubers that is really driving the seizures. So it actually is possible to resect the tubers that are causing the seizures and for these patients to be seizure-free following surgery. This requires very careful workup because the whole brain is abnormal. You have to really be sure which of the tubers are causing the seizures before you start taking parts of the brain out. And so the image here shows kind of the way we approach these surgeries and the workup. There's a lot of initial testing done with EEG, MRI, some more advanced imaging to try to localize where the seizures are coming from. But before having surgery, these patients will also have electrodes implanted actually into the brain. And so this image, the dots in the line, show the different places that electrodes were implanted in this patient with tuberous sclerosis. They're usually put into multiple tubers, as well as some of the perituberal tissue to see how the seizures are spreading and decide which tubers are the ones that need to come out. And so the surgeries that can be done, it's possible to just take out a single tuber, but often the surgeons will take out a group of tubers. Sometimes they'll take out a whole lobe if there's multiple tubers within that lobe causing surgery. And occasionally they will actually disconnect a whole hemisphere to try to stop seizures. And there's good evidence that this works, that this is helpful for patients. And so this is a retrospective study that was done looking at patients that had undergone surgery for tuberous sclerosis. They were older, so some children as well as some young adults. And they were able to show that 60% of these patients were seizure-free at 5-year follow-up. And so this is a really excellent outcome. If you look at patients with tuberous sclerosis who have refractory epilepsy, our chance of achieving seizure freedom by just adding another medication is less than 5%. So this is a really impressive chance of being seizure free. Maybe not forever, because one of the other tubers may sort of take over and begin to generate seizures, but for years following the surgery. And they also showed here that patients that had had successful surgery had an improvement in their IQ and also improvement in quality of life. And then finally, the next sort of where surgery is going is this idea that maybe we should be doing surgery earlier. So for all epilepsy surgery, we wait till patients are refractory, the medications aren't working. But there's often a hesitation to do surgery in younger patients, probably more traditionally kind of worrying about young age and surgical risks, although there really aren't any increased surgical risks in this population. And in tuberous sclerosis, we've talked about how we think that if we could just control the seizures, we could really improve the developmental outcomes. This study tried to look to see if you did early surgery, and that was at less than 2 years of age, if you could change the developmental outcomes. So they compared 19 children who had undergone this early surgery with other children who didn't have seizures, controlled seizures versus refractory epilepsy, but no surgery. Of the children that had the surgery, 53% were free of disabling seizures. So these are definitely not as good numbers as the previous study, not as good an outcome. And it's probably because in the first paper, the patients that were operated on were very carefully selected, whereas these patients had more severe seizures to begin with and probably more of their brain involved. But they were able to show also that a favorable surgical outcome was associated with at least a slower decline in their language scores. So not the most impressive change in kind of cognition and intellect, but at least a suggestion that the early surgery is helpful. So this is definitely the way we're going with tuberous sclerosis, is identifying seizures if possible before they start, if not right at the beginning, treating quickly and aggressively with initially Vigabatrin and then other antiepileptics. And if the antiepileptics don't work, moving very quickly towards surgery for these patients. Okay, so I've talked about the Vigabatrin and the epilepsy surgery. I'm going to turn it over to Nirav now to talk about the molecular targeted therapies for mTOR.
Okay, so thank you. Good morning, everyone, and thank you, Katie and Sarah, for making my job really easy, because now that everybody has understood the mechanism of action and the pathophysiology, I just have to talk about targeted therapy. So overall, we are actually in an exciting area of targeted therapy and immunotherapy in general in medicine, and with tuberous sclerosis actually being one of the early beneficiaries of this therapy. So for hitting the right target, it's very important to have the right trajectory. And when the target is medical, translational research actually provides that trajectory. And over the next 15 minutes, we'll try and see how it has transformed treatment in TSC and starting and ending back to the clinic. So as you already heard from Sarah and Katie, we start with the clinical problem. We'll go on a molecular expedition. Then we need to find the molecule, which is the right fit. And then eventually targeted therapy comes back to the clinic. So identification of all the problems that need to be taken to the lab should begin at bedside. And it's no different with TSC. And as Sarah very nicely outlined all the organ systems that can be affected by TSC, it is important to identify the organ involvement, which are very common and cause significant morbidity and mortality, so that we know what problems we target initially when we want to get a new therapy. And essentially brain with manifestations of epilepsy, SEGAs, TANs, as already Katie highlighted, and kidneys with renal AML are those organ systems in TSC which need to be targeted early. So once the clinical problem is identified, then we begin the molecular expedition in lab, which Sarah again showed with various tools that we have now. And although tuberin and hamartin were identified earlier, the role of mTOR pathway only got established in 2001. Since then, various upstream and downstream pathways with TSC complex have been identified, including MEK and ERK pathway, AKT-PIK3 pathway, and as we can see in figure, right, and making tuberous sclerosis even more complex than already complex, which is in its name. So let's try to unravel this complex and get a more simplistic view. Fortunately, the major effective pathway of TSC complex functions through mTOR complex 1 or mTOR C1, which you will see. And basically it has three components. First one is upstream, which actually is by AKT and ERK pathways. And then there is a predominant TSC complex, followed by a downstream pathway, which is actually through mTOR C1 or the complex 1. And the majority of the manifestations are actually because hyperactivation of mTOR C1, because there is mTOR C2 as well, as we saw in the other diagram. But this makes it easier because majority of them are through mTOR C1. And as there are multiple upstream pathways and primary mutations in TSC are actually in the TSC complex, which is in the center. So target essentially needs to be downstream. And that means we need to target the mTOR complex, because anything that we target higher than that is not going to help us, because that's the common pathway through which everything channels out. So once we sort of have that understanding, we actually try to find the right molecule that fits this target, because now we've identified the target. And as you can see in these pictures, I haven't put just so that they look nice. They actually have a quite significant contribution to treatment of TSC. These are actually MAO bodies that are found on Easter Island, and we'll try and see what has been the connection of Easter Island with tuberous sclerosis. So luckily for tuberous sclerosis, the molecule had found itself decades earlier and was waiting for us to find the right target, which actually is evident from the name of the mTOR, if you see. So mTOR actually means mammalian or mechanistic target of rapamycin. So the target is actually named after the drug. And the drug is actually named after Rapa Nui, which is another name for Easter Islands, because it was one of the antifungals that was isolated from the soil of Rapa Nui by Dr. Sehgal, actually in Montreal in 1970s. And then for almost 30 years, we had a drug, but we did not have a target. And eventually now we have multiple mTOR inhibitors, but the most popular ones are sirolimus and everolimus. Sirolimus is actually rapamycin, which is a drug that was isolated. Everolimus is a derivative of sirolimus, but it's much more pharmacokinetically favorable, and that's why that's used more often. So now when we had actually both the drug and the target, the final step was to translate it back to clinics. And the best way to do that is actually through clinical trials, so that we can get the appropriate regulatory approvals for that. And the entire existence of everolimus in TSC is actually based on 3 EXIST trials. All the EXIST trials were randomized placebo-controlled trials, and actually all 3 of them were published in Lancet. So as you can see here, this is the EXIST-1 study, which was published actually back in 2013, and which showed significant response in SEGAs with TSC, and was also instrumental in getting FDA approval for the same. And as you can see, 35% of the patients actually showed response, and response was defined as more than 50% decrease in the volume of the SEGAs as early as 6 months, and the median time to response was 9.6 months. Median follow-up was 9.6 months there. And with the extension phase of this study, which was taken for a longer time, actually they saw that the response was better. So 58% actually had a response, and also was sustained, because now they have responses at even 4 years after starting the therapy. And the median follow-up for these patients was around 47 months. So overall, more than 100 patients demonstrating good responses. This was an amazing study which got them FDA approval. And as you can see, almost 88% of the patients had no progression while they were on everolimus. And the median time to response was as quick as, actually the median time was 5.3 months, with lowest being 2.5 months. So early responses, longer responses, sustained responses, and an FDA approval. The other interesting thing with these things were that while the patients were on everolimus, none of them actually required surgeries for SEGAs. And the other thing to remember for targeted therapy, and this is with most targeted therapies, is that when the therapy is stopped, there is a good chance that the tubers will start growing, or the lesions will start growing, which was the same for SEGAs. And therefore, at present, we continue them till they are tolerated well, and we actually don't have a stop date for any of the targeted therapies. So then moving to EXIST-3, and I will cover EXIST-2 later because it is more of adult predominant, but EXIST-3 again was mainly pediatric, and they actually had looked at seizures in EXIST-1 as secondary outcomes, but because they were looked at as secondary outcomes, they couldn't get an approval for that, and that's why they actually did a large study. With this had more than 300 children, specifically looking only at seizures, and children more than 2 years were eligible to participate in this study. And again, the response was defined as decrease in seizure frequency by more than 50%. And as you can see, they had 2 doses of everolimus in this, which was a lower dose and a higher dose. So the early response was better with the higher dose of everolimus, and almost 43% had a response. But as you see, as we go further away, more patients did have a response, but the difference between lower and higher dose was not that significant. So essentially, we know that we can use a higher dose, but we know that in long term, lower dose versus higher dose is not very different, especially because a lot of patients also had to discontinue therapy because of increased toxicity in these studies. So overall, because of this study, they actually got FDA approval in 2018 for refractory seizures in TSC. And then finally, I think coming to EXIST-2 study, this was predominantly an adult study with all participants being more than 18 years. And again, you can see, right? I mean, amazing responses, very good early responses. 42% of the patients with renal AMLs actually had response. And again, response was defined by more than 50% decrease in the volume. And an extended analysis as well, it was sustained and improved at 4 years. So almost more than 50% had responses, delayed responses as well. There was a secondary endpoint of skin lesion in the study as well. And even there, they saw responses in more than 25% of the patients. Again, almost 90% of the patients did not progress while they were on therapy, and none of them required any surgery while they were on therapy, with only 1 patient who actually required embolization. So even none of them required embolization except 1 from 112 patients. And because this was a predominantly adult study, investigators then went back and looked at EXIST-1 study, where they had data, but actually did not look at it in an objective way. So they went back and did a post-hoc analysis from EXIST-1 study, where there were 33 patients with renal AMLs, and they actually showed 80% responses, which were sustained. So 80% response at around 24 weeks of therapy, which was sustained for almost 4 years. So overall, the major clinical problems that we had identified, all of them seems to have done well on actually phase 3 placebo randomized control trials. So highest level of evidence, and all 3 of them post their trials got FDA approval for the same. However, no therapy is without toxicity. targeted therapies do have different toxicity profile than chemotherapy. And therefore, we need to be aware about the common toxicities that we encounter with these therapies, because we can always adjust the doses and try and look. Because it's important to understand that although these are targeted therapies, the dosing is still based on the age-old formula of maximum tolerated dose. So we actually don't know what is a biological optimal dose. We only know what is a maximum tolerated dose, and we are basing all our dosings on that. So once we have more toxicity, we can always try and come down on the dose and see how it does with the responses. Although there is no clear data on this, but in most of the studies, they have come down as per the criteria with this. The most important actually is stomatitis. Although you can see all the others, the infection is more of an issue in infants rather than in the older kids, and it's mainly respiratory tract infections. And apart from that, the rest are really minimal, but we need to keep an eye out so we can identify and actually help the patients early. So with that, to summarize, mTOR inhibitors, we've actually hit bullseye in TSC for most conditions, and we are working on a few more. So the trials were so good and the responses were so great that there is FDA approval now for SEGAs, for renal AMLs, and refractory partial seizures. As we already saw for TAN, there were 2 phase 2 studies, both of which were negative. However, there are bigger studies which are still ongoing. And if you go back to Katie's diagram, which she had showed earlier, most of the changes happen in infant brain. And both the studies which were for TAN actually were at the age of 2 years was the first one, and the other one was 4 years criteria for entry. So there is general consensus. It seems that we are starting it a bit later, and maybe starting them earlier would help. And there's another condition which Sarah highlighted earlier in the lungs, which is lymphangioliomatosis. Everolimus actually has an FDA approval for that as well. So most common clinical conditions, most morbid and mortality associated clinical conditions, we now have an option of using targeted therapies in TSC, like a lot of other neurocutaneous syndromes as well, including NF1. And in coming years, it's going to be more and more the way the medicine is heading into. So with that, I'd like to thank and hand over to Katie, who will actually now speak in brief about the TSC clinic that she's planned.
Thanks, Nirav. Okay. So the reason that we had wanted to do this grand rounds today and talk with everybody was obviously tuberous sclerosis is a very interesting condition, and also a condition where there are just tons of advances going on right now, both in diagnosis and in therapy, and a condition where we really feel like early diagnosis and therapy can change outcomes for this patient population. And so based on this, we are starting a tuberous sclerosis clinic here at CHEO. So this is going to be a multidisciplinary clinic for patients who have tuberous sclerosis. The goals of our clinic will be to ease the access to subspecialists and required screening tests. I think you've probably gotten a sense throughout this talk that this is really a multi-system condition, and there are many, many subspecialists who follow these patients, and they require regular screening for complications. We'd like to be able to identify seizures early, hopefully before they actually start. Provide easy access to the molecular targeted therapies for mTOR, which I think is really the way treatment is going to go, earlier access, earlier treatment with these. Because it'll be a multidisciplinary clinic, it'll allow us to have a multidisciplinary review as well of our more complex patients who really need input from different subspecialists to guide care plans. And then, of course, we're hoping this is sort of a quickly moving field from a research point of view, that we'd be able to identify areas of knowledge gaps and promote research in tuberous sclerosis here at CHEO. And so this is the group that's going to be a part of the clinic. So as you can see, multidisciplinary, Sarah, Nirav, and I, we also have psychiatry, neuropsychology, cardiology, nephro, dermatology, neurosurgery, and ophthalmology. If there's anybody who's interested in the clinic and your name is not on this list, we'd always be happy to have you be a part of it as well. You can just contact one of us. So then who should be referred to this clinic? Of course, we'd hope that everybody with a new diagnosis of tuberous sclerosis could be referred to the clinic, but also anyone who has a suspected diagnosis of tuberous sclerosis, because as Sarah has been talking about, there's so much more we can do around diagnosis of tuberous sclerosis now to try to confirm this for patients and their families. So the main message here is to refer early. And the way you would refer is that you can just send a referral to neurology for tuberous sclerosis or possible tuberous sclerosis, and we'll triage it through the neurology system into the clinic and sort of assign to subspecialists as needed. Okay. So that's all I have. I think maybe the last thing is also just to say that the tuberous sclerosis clinic is what we're launching first, but Sarah and Nirav and I also would like there to be kind of a more like a broader neurocutaneous program here at CHEO. And so this would hopefully be one component of what would in the future be a bigger neurocutaneous program. Okay, I think that's it. We can take any questions.
Hey, thank you, all of you, for that amazing presentation. You significantly increased my knowledge of tuberous sclerosis. A lot has changed since I'd last thought about this in a real way. And I think it's really exciting what you're planning, for this tuberous sclerosis clinic in particular, but also looking more broadly as neurocutaneous syndromes and bringing the experts together around a patient, I think is a really exciting way to go, and integrating research into that as well. So kudos to all of you for leading this and for getting us thinking this way. I was going to open to questions and invite Dave Diamond, a new entrant into Grand Rounds, to give his comments. I see he's put some in the chat there. I don't know, David, if you want to say something out loud. Give you a second.
No, I mean, other than I really enjoyed the talk. It was wonderful, and it was great to see all three people give this talk. And I think the clinic is going to be a very exciting avenue for treatment, but also, as they say, for research. And I think it's a great idea. Yeah, I did see a question about newborn screening, and I agree with Sarah. I'm not sure if they're going if there's any formal plans, but I do know that Pranesh does have an interest in this because of the early treatment potential. So I think certainly he would be someone to chat more with.
Yeah, that's a great suggestion. It would be a great tie-in, given you have this new clinic. It would be really great to tie in the early screening and get those patients in even sooner, and do that in an integrated research way would be really fantastic. I'll just ask if anyone else wants to ask a question. They can just go ahead and unmute yourself and ask, or raise your blue hand. And I'm just going to chat. I'm just going to scan the chat to see if there are any other questions in there. I don't know if anyone wanted to respond to the question about the newborn screening while I'm looking.
Yeah, I don't have any more to say about the newborn screening, other than I think it's a good idea as well. I mean, the whole like trying to catch them early, trying to do these screening EEGs and identify before seizures. I mean, I think, and start them on Vigabatrin at that point, that it's sort of, I would say, becoming the standard of clinical care. And I think in the future, looking at the mTOR inhibitors as we get more safety data in the younger patients, I think there's likely we're going to switch from using Vigabatrin to actually using the more targeted mTOR inhibitors for these patients, and using them early, with the hope that it would not just affect the seizures and epilepsy, but maybe also be able to address more of the TAND if we were to start it earlier.
I'll just add that many patients actually are diagnosed prenatally when we see the cardiac rhabdomyoma. So testing certainly does happen in pregnancy if we see one of those major features, and the cardiac rhabdos are relatively common. Okay,
that's an interesting point. So what proportion would you say of patients that get diagnosed are diagnosed prenatally versus sometime, and are they diagnosed much later in infancy or childhood if they're not diagnosed prenatally?
Yeah, the average age of diagnosis is 2 to 6 currently, but that's probably not the most up-to-date data, but that's generally what's said. I certainly diagnosed many later on who are probably mosaic or milder, so my ascertainment bias is skewed. But certainly when I cover prenatal genetics, it's not uncommon to see the cardiac rhabdomyomas. So it's a little bit, where you are coming in is what you see. I don't know what the real numbers are. But cardiac rhabdomyoma is common, at least 50%, if not much higher, it's present in patients.
So thank you. I guess there's another question generally about how these clinics are going to run. You've got a huge list of subspecialists that are going to be participating. Can you just give us a bit of a sense of how that would run? And I see from Nirav's note that you're looking for a pediatrician to get involved on the team as well. So if anyone is interested, you can contact one of these three. I don't know if Katie's the one that's leading this to declare your interest, but can you just talk a little bit about how you're planning to run this clinic?
Yeah, it's obviously a big group of subspecialists that are involved. And so the clinic will run out of neurology and probably run at least 3, maybe 4 times a year as we get started. So every couple of months with a combination of new referrals and then the follow-up patients that I'm already following. And the way we're going to start with running it is that it'll run out of the neurology clinic. So obviously I will be seeing them as sort of the main provider. And then I'm trying to organize the patients so that if I have a group of patients with sort of new genetic diagnoses or with questions around their genetic diagnoses, then Sarah would come to that clinic and she would sort of see the patients at the same time as me in the clinic. We're going to do one in a couple of weeks where Nirav is going to come and talk to some of the patients about mTOR inhibitors. And so we will have sort of me as the primary and then subspecialists where there's sort of a group of patients that need to see that subspecialist to kind of ease their access to that, to make it a little bit faster for them to get in to see genetics or the oncology. And then the subspecialists that probably don't see as many kind of severe and active patients obviously won't come to every clinic. But what we had thought to do was run it more of like a multidisciplinary round. So following every clinic, taking the list of patients that we're seeing, inviting all the specialists that are involved in their care, and then just running kind of an hour or so of rounds where we discuss each patient. And so the specialists who are following them can all have input on the care for those patients. And I think that's especially important, I'd say, for the involvement for psychiatry and psychology, which I really can't highlight enough is such an important area for these patients, and the families struggle so much. So we're really happy to have Dr. Hugo and Annalise Holohan helping with the clinic.
Wow, that's so amazing. It's really such a wonderful model for true multidisciplinary care and really wrapping around the patient and bringing in the experts as they're needed around the patient's timing and schedule. So I really think it's exciting and a really great way forward. So thank you for presenting that to us today and sharing your expertise on this subject. With that, we are at time. So thank you again. Have a wonderful day, everyone, and see you next week.
Thank you, everyone, for listening. Bye.
Bye.